Now, T2 weighted MR images depicts very beautifully the zonal anatomy of uterus. It has got an inner high signal zone, which is formed of endometrium. It is of high signal because of mucin-rich endometrial glands. The middle layer, or the inner myometrium, or the junctional zone, is of low signal on T2. This is because of its compact, smooth muscles and low water content. And the outer myometrium, which is outer to the junctional zone, is of intermediate signal. This is because of its higher water content, less compact, smooth muscles, and more blood vessels. Now, cervix also has got a beautiful zonal anatomy that's seen on T2 MR. The central endocervical mucosa with secretions will appear high signal. The main bulk of cervix is formed by its middle layer, which is again low signal on T2. This is mostly formed of fibrous stroma, and that is contiguous with the junctional zone of uterus. Again, there is a thin, small outer layer, which is low to intermediate signal on T2. On CT, you will not see the zonal anatomy. Endometrium can be seen as a central low signal, low density area, which may be sometimes misinterpreted for fluid. You can see in the post-contrast image, cervix enhances to a lesser extent than the myometrium. This is because of its larger fibrous content. Now, again, the normal appearance of ovary. As seen with uterus, ovary also has age-wise differences, changes. When in the newborn period, it's common to see follicles and small cysts, but during rest of the prepubertal period, you see only very few number of follicles and cysts are uncommon. Again, during reproductive age group, you will see several small follicles and cysts or functional cysts are common. So we have an adult ovary here, tiny follicles are there. This is a dominant follicle, and by definition, it is less than 3 centimeter. Following its rupture, when it releases the ovum, what is left behind is the corpus luteum. It has got thick irregular wall, which is very vascular, and it is important to be familiar with this appearance, as this becomes an important differential for ectopic pregnancy. And this is how a corpus luteum would look on CT and on MR. So we'll now see a normal MRI pelvis and PACS model. Give me one moment to get back to that PowerPoint. Are you able to see the normal MRI pelvis?
You can see the presentation, just like the word normal MR pelvis.
Normal MRI pelvis, yeah. Thank you. And so, oh, sorry.
Sorry, I can only see the title page of the PowerPoint, so I can't see you in a PACS screen, if that's what. Yeah, sorry.
One moment, I think I've confused, messed it up a little bit.
Anjali, we can see a slide on which normal MR
pelvis PACS model is written. Okay. And when I scroll up and down, I can actually, it's actually showing my original presentation.
So what do you want to show?
Let me come out of it again.
So we can see MRI pelvis written on a new PowerPoint now.
I think it is the same slide that is being projected.
We can see your new presentation now. This is a separate presentation. So this is got MR pelvises, and then the second slide is sequence.
But that was a slide which I had kept for me to remind myself, because the next slide, which is showing, is the original presentation slide.
Yeah, Anjali, you were on it. You know, we could see a slide in which you had given a clinical, and I believe you had to show it to the candidate. If you go back, you were there actually.
Okay, let me. Share. This is A to Z. This is. So these are the basic sequences that we do. So depending on the pathology, we might add pre and post contrast sequences and the diffusion weighted and ADC maps. We are now starting with the T2 axial of a normal MRI pelvis. As we come down, we can see the left ovary. We can see a normal right ovary. You can see the uterus coming up with the endometrium, junctional zone, and outer myometrium. This is the cervix. There are small Nabothian cysts there. So this is a normal T2 axial. So if you're given a slide where you are not sure which T1 or T2 it is, then look for clues, like look at the urinary bladder, look at the endometrium. If they are bright, then you are looking at a T2 image. On T1, basically, you cannot differentiate between the, you cannot actually see the zonal anatomy. Even the ovaries would look hypo intense. And then we have a fat saturated T1 axial. Look at the bones, the marrow would look darker. And then again, we cannot differentiate the zones. It's a normal sagittal. We can already see a ovary has come up. As we come down, the beautiful trilaminar, zone anatomy of uterine body and cervix. And then finally, we have a normal coronal. Okay, so now I have to come out of it. New share. Can you all see this now?
Yeah, I think we're back to the original.
Okay.
Yeah.
Okay. So here starts the first case. You're candidate number 1, aren't you?
Yes, I am. Yeah.
Okay. So this is a 28-year-old female investigated for infertility. Can you describe?
Okay. So I am presented with a hysterosalpingogram. I don't have a control, so this is where the speculum is already in and inferior at the, in the vaginal os, and the cervical os has been cannulated and contrast has been instilled, and a single uterine cavity that is not normal, like not entirely complete. It looks like a unicornate cavity with a single fallopian tube on the right with good spill of contrast through that, so a patent fallopian tube on the right. The differential for this could either be that there is a unicornate uterus, or that this could be a didelphic uterus and there are 2 cervices and only one of the cervices has been cannulated.
Good.
So I would,
yeah. Okay, good. So we'll come back to the same slide again. So first, let's have a discussion on this slide. So that takes us to Mullerian duct anomalies. So these Mullerian ducts are paired embryologic structures which undergo fusion and resorption and give rise to uterus, fallopian tubes, cervix, and the upper 2/3 of vagina. Remember, the lower third of vagina and ovaries have completely different embryology, and so Mullerian duct anomalies are not associated with abnormalities in ovarian development or abnormalities in external genitalia. But these are commonly associated with renal abnormalities. And so when you diagnose Mullerian duct anomaly, it is important to look for both kidneys. Renal anomalies are commonly renal agenesis, ectopic kidney, malrotation, or renal duplication. Mullerian duct anomalies have been classified into 7 different subgroups. We will be focusing on uniconvate from the 2nd till the 6th ones. If we look at uniconvate uterus, it is important to spend some time on this slide so that it becomes easier for you to tackle the next few slides. So uniconvate uterus is again subdivided into 4 types. A uniconvate with a rudimentary horn that is communicating with the main cavity. So this has got functional endometrium. Second subtype is uniconvate uterus with a non-communicating rudimentary horn with functioning endometrium. The third one has a rudimentary horn without any cavity. There is no functioning endometrium. And the fourth type doesn't have a rudimentary horn. Amongst the 4 and amongst all these abnormalities, the second one, that is the one with non-communicating functional endometrium, is considered to be the most significant of all. This is because of the presence of functional endometrium, there will be cyclical menstruation. In the subtype 1, the menstrual blood can be discharged in the normal way, whereas here, because there is no communication, it results in retrograde menstruation. So there will be a hematometra first, leading to a hematosalpinx, and then with spillage of blood into the peritoneum. It is very commonly associated with endometriosis and endometrioma. The uterine didelphys is when the Mullerian ducts do not fuse at all. So you get 2 completely separate uterine cavities, 2 completely separate cervix and the upper vagina. Whereas in a biconvate uterus, which can be a complete or partial type, in the complete version, there are 2 separate uterine and cervical cavities. There is some degree of myometrial fusion. In the partial type, there are 2 separate uterine cavities but a single cervix. When we come to septate uterus, there is a division of the uterine cavity into 2 by a midline septum. It can be complete or partial. Now, how do you differentiate between didelphys, biconvate, and septate uterus? So here comes the key factor. It's the fundal contour, external uterine fundal contour, that decides which is which. So if you look at didelphys uterus, you can see the external contour, it just dips in. It is heart-shaped. Same goes for biconvate uterus, whereas in septate uterus, it has its normal convex contour. And so, hysterosalpingogram has limitations in showing the fundal contour. So you have to ask for an additional imaging which can show a proper fundal contour. So these are the key points to remember when regarding Mullerian duct anomalies. Associated renal anomalies are there, and external uterine fundal contour is a key component of MDA characterization. Now, when you assess uterus for fundal contour on MRI, you have to get a true coronal of the uterus. This is achieved by planning the coronal slices parallel to the long axis of endometrium. So, and thus you get, which will show the smooth contour of uterus. Now, this is a normal hysterosalpingogram showing the distended uterine cavity, tubes with bilateral spillage. Let's come back to the first case again. Now, how will you approach this case again? Candidate number 1.
So this is a hysterosalpingogram where cervix has been cannulated and contrast instilled. This is a unicornate, so a single uterine cavity communicating with a right fallopian tube with healthy spill. I cannot see a left side, a uterine cavity on the left side, and or a left fallopian tube. So my differential remains whether this is a unicornate uterus. It doesn't. There's not no communicating communicating a rudimentary horn, and I would need to ascertain from the person that was performing it whether there were 2 cervices or not, and also further investigate with an MR.
Okay, so here you go.
Okay. So I've got coronal views, and then the third image is focused on the pelvis. There are two uterine cavities that are separate. However, they seem to meet in the, so there's two separate uterine cavities, and the uterine fundal contour is completely separate. I can't see the cervix on this
Okay.
view.
Can you see if the two uterine cavities, are they communicating with each other? Can you see if...
I can't see that they are on the images that I've got. They seem quite separate. Although the second image, they could be coming down lower to communicate, but I'm not. It doesn't appear on the views that I've got. I don't think they are.
So in the views that you've got, you can see two separate uterine cavities.
Yeah.
And they are not communicating.
No.
Yeah. And the first one has got the appearance of a well-formed uterine cavity, and the other one sort of looks like a rudimentary, but it's got endometrium inside.
Okay.
So we were actually looking at a uniconveate uterus with a non-communicating left horn with functioning endometrium.
Okay.
Okay. So this is subtype 2B. Okay. And is there anything else that you can see?
I can see that there is a normal right kidney, but an absent left.
Well done, well done. So these are commonly associated with renal anomalies. So if you're given a Mullerian duct image, make sure that you ask for an imaging to look at the kidneys.
Okay.
Good. So yeah, the two separate hysterosalpingogram. Describe the first one.
So the first hysterosalpingogram has a single cervical canal and then two separate normal morphology uterine cavities that are completely separate and have normal spill into the fallopian tube. There is an impression of communicating rudimentary horns to the right and left. Although by the nature of a dynamic study, I would just want to exclude that wasn't spill that was then collecting in the pouch of Douglas.
Okay, forget about the peritoneal spillage. Let's focus only on the morphology of uterine cavities.
So definitely kind of two normally formed morphology separate uterine cavities that then join into a single cervices. So this would be consistent with a bicornate uterus.
Okay, and what about the one on the right side?
This one has got two separate uterine cavities that meet in the middle, and I feel that this is more, but meet quite far earlier than the case on the left. So I think that this might be more likely to be a septate uterus potentially, but would need to look at the fundal contour to confirm.
Excellent. So if you're given this, again, you have identified it is a Mullerian duct anomaly, and then the key component here is external uterine fundal contour. And as in any Mullerian duct anomaly, you have to ask for that I would like to look at the renal status as well. So here you have the MRI. Shall I take over from here? So we can actually see in the first case, you can see the external fundal contour, it's dipping in, it's heart-shaped. Whereas here, in the second case, it has got a smooth convex external contour. So we are actually looking at a bicornate uterus, partial bicornate and partial septate uterus.
Okay.
Clear?
Yes.
Okay. So this is, what is this? Diagnosis?
This will be a didelphic uterus because there's two separate cervical canals and two separate uterine cavities in fallopian.
Correct. So you've been separately cannulated, two separate uterine cavities, not communicating. So this is uterus didelphys. This is a inverted negative image of a hysterosalpingogram. What do you think is happening?
You've got I think it's probably an anteverted, anti-flexed uterus that has got it's almost normal, but just a little bit more emphasized. So potentially an arcuate uterus.
Yep. Good. So this is an arcuate uterus where it's essentially a normal uterus, except that there is a prominent fundal impression on the upper part of endometrial cavity. So this is an arcuate uterus. So that brings us to the end of congenital anomalies. So your Chapman has classified endometrial abnormalities to diffuse and focal abnormalities, conditions having both endometrial and myometrial abnormalities, focal and diffuse myometrial masses. So, but in this session, we will be focusing on endometrial CA, fibroids, and adenomyosis. Okay. So thank you, candidate number 1. Shall we have candidate 2 unmuted, please?
Hi.
Hi. So are you ready? So this is a 40-year-old female, presents with menorrhagia and dysmenorrhea. Identify the sequences first.
Okay, so we have anaxial T1, coronal and sagittal T2.
Okay. Describe your findings.
So the endometrial cavity is expanded, as is the cervix, with a lesion which is low signal on T1 and heterogeneously low signal on T2. There's normal endometrial cavity surrounding the lesion within the endometrium. I can also see fibroids within the uterine wall. In these limited sequences, I can't see any free fluid in the pelvis, and I can't see any pelvic lymph nodes. I think findings will be in keeping with large fibroids.
Okay. Location-wise, good. These are multiple fibroids. So fibroids tend to be of low signal on T2, and they typically are in 3 locations. Most common is intramural, the second subserosal, and the least common but the most symptomatic one is the submucosal. So this is a scan that shows all 3 locations. So on T1, it is low to intermediate signal. Signal changes can depend on the presence or absence of degenerative changes, most common being hyaline degeneration. It's consequent to which we can see calcification within the fibroid. It can undergo cystic degeneration, red degeneration, which is commonly seen in pregnancy, which is essentially a hemorrhagic infarction with presence of hemorrhagic changes within the fibroid. Essentially, the MRI sequences taken for a fibroid or endometrioma protocol are the same. We need 3 planes of T2 axial, sagittal, and coronal, a T1 axial and fat sat. Now, as a routine, you would not require contrast, but if there are any complex features, we might add a contrast sequence as well. Now, I've given the diagnosis. This is an ultrasound scan showing submucous fibroid, but this is a special type of ultrasound scan. Can you name this study?
It's a transvaginal ultrasound.
It is a transvaginal ultrasound, but there's something more into it. Okay, I'll take over. So this is called a sonohysterogram. This is sonohysterography. Essentially what we do is we introduce a catheter, position it in the cervix, and instill normal saline into the cavity, uterine cavity. And simultaneously, you do a transvaginal scan. So endometrial abnormalities like endometrial polyps, carcinoma, and things like submucous fibroid projecting into the endometrial cavity will be beautifully depicted against the fluid background. So it's just for you to be aware of sonohysterography, which is widely practiced. Okay. This is a case of parasitic leiomyoma. Can you describe the findings in the available views? I've given a sagittal and a coronal view. Describe the findings.
Okay. So there are multiple heterogeneous, predominantly low T2 lesions within the endometrial cavity, but it can also appear to be outside the endometrial cavity and within the abdomen. On the coronal image, there appears to be at least 4 fibroids in the left upper quadrant, which is displacing the bowel to the right-hand side.
Yeah, good. So,
And the uterus is filled with fibroids.
yeah, so this is a case of multiple fibroids. So what happens here is we cannot actually see a connection of some of the fibroids, which is actually within the abdomen, to the parent uterus. So what happens sometimes is a leiomyoma sometimes gets attached to adjacent structures like omentum or broad ligament. It gets new blood supply from these structures and then loses its original attachment with the uterus and then becomes parasitic. So if you're given a case, you will be getting the PACS model, or you will be able to scroll it down and it will be more clear in the cases given to you. So when there will be no connection that you can establish with the parent uterus, then you call it a leiomyoma, parasitic leiomyoma. Yeah, candidate number 2.
Okay, so we have selected MR images of the pelvis. The top left is a axial T1, T2, and then I think we have dynamic sequences post-contrast.
Yeah, the dynamic post-contrast sequences are at the bottom, and this is a fat-saturated T1 axial.
Okay. So there are large rounded lesions, which appear to be the possibly ovarian, and they demonstrate intermediate low signal on T1, high on T2, and do not demonstrate any suppression on the fat suppressed sequences. So the findings will be in keeping most likely with a blood product. Having a look at the dynamic sequences, I can't see any enhancement of these lesions. So in summary, this would probably be in keeping with hematosalpinx or some sort of blood product. And
Okay.
yeah.
Okay. I'll take over from here. So you have correctly identified blood products. Good. When you actually look at it, the structure on the left side, it's low on T1, high signal on T2, and it is still of low signal on fat saturated. So it does not show a hemorrhagic signal, whereas the larger lesion on the right does show hemorrhagic signal. It is of high signal on T1 as well as the fat saturated images. If you actually look at the post-contrast image, we can see that the larger lesion has got a solid component that is enhancing to the same extent as the uterus. It is sort of connecting it to the uterus. Even on the left side, the lesion, the smaller lesion, has got an enhancing solid component which is attached to the enhancing uterus, and that solid component enhances to the same level as the myometrium. So these are pedunculated subserosal fibroids which have undergone degeneration. The smaller one has got cystic degeneration, whereas the larger one shows hemorrhagic changes as well. Okay. So in the exam, it's less likely that you'll be shown a simple, straightforward case of a T2 low signal fibroid. You're more likely to show more complex cases like with degeneration or with prolapse or with torsion, things like that. So I'm going to show you a PACS case. Sorry. Okay. Can you see a slide saying prolapsing submucous fibroid?
I can, yes.
Okay. So this is a case which I've taken from Radiopedia. So if you, during the T2 axial sections first, so you can actually see a large mixed or intermediate signal mass within the uterine endometrial cavity. We can actually see the connection coming from the mucosal level, just from the inner myometrium. It's coming into the endometrial cavity and prolapsing into the cervix. So on the coronal image, again, you can nicely see the attachment. It is a pedunculated submucous fibroid, which has undergone degenerative changes and filling up the endometrial cavity and prolapsing into the cervix. So this is a still sagittal image. You can nicely see a submucous pedunculated fibroid prolapsing into the cervix. So this is a 2B case. Prolapsing submucous fibroids have been asked in the exam. And so it's important to be familiar with the images. So now going back to my original presentation. Oh, sorry. Finding it again difficult to find my, okay, yeah, got it back. Okay, yeah, thank you, candidate number 2. We are moving on to our next pathologies. So candidate, who is ready now? Candidate 3?
Hello.
Oh, hi. So this is the case of a 42-year-old female with chronic pelvic pain. Now focus only on the uterus. Can you describe the uterine findings?
Anjali, can you go to a PowerPoint mode, you know, the slide mode,
Yeah,
because
sorry,
we,
yeah.
now
Okay.
you are fine. You are fine
Okay,
now.
yeah. Thank you. Thank you. Yeah, 42-year-old female, chronic pelvic pain. I've given you a single sagittal T2 image.
Yeah.
Can you explain the uterine findings?
So on the sagittal view, we can see that the uterus appears quite bulky with a heterogeneous but low signal, particularly on the posterior wall. I can't definitively identify the junctional zone.
Okay.
So in a patient with this history, you would consider adenomyosis, particularly with those high T2 signal foci in that posterior fundal wall.
Good. Good. So, yeah, this is a case of adenomyosis. So, when you go back and look at your zonal anatomy, this is the junctional zone, and it is maximum thickness should be 12 millimeter. So, in our case, we can see diffuse thickening of the junctional zone, which is more in the posterior myometrium. We can see tiny cystic signals within the thickened junctional zone. These are enlarged endometrial glands. And this is adenomyosis. This is the picture of adenomyosis. It can be sometimes focal, diffuse, and on T1, sometimes because of the presence of menstrual bleed, you might see tiny hemorrhagic signal, which will be bright on T1, as well as T1 fat saturated images. We'll see more cases of adenomyosis when we cover endometriosis. Okay. So on adenomyosis, on ultrasound, it has got a very particular appearance. The uterus will be enlarged, will have heterogeneous echogenicity. You will see echogenic stripes extending from the endometrium to the inner myometrium. You can see echogenic nodules, myometrial, subendometrial cysts, And overall, this heterogeneous appearance of uterus looks similar to what you get in liver cirrhosis. And sometimes we call this condition cirrhosis of uterus. Okay, so less likely that an ultrasound may be asked, but it's important to be aware of this appearance. Now, candidate number 3.
Okay, so I have selected sagittal and 2 coronal sequences through the pelvis for a 78-year-old female with postmenopausal bleeding. There is an abnormality in the uterine cavity where there is a low to intermediate T2 signal mass, which on the post-contrast images demonstrates some mild enhancement, particularly at the posterior border. There's also some fluid within the endometrial cavity. Based on these images alone, I think the myometrium is of normal thickness, but there is possibly on that second image, I think that there is some invasion into the myometrium. I think my differentials for this would include either, and I think they're suspicious for an endometrial cancer, but I would also consider this likely an endometrial polyp. They'd probably need a hysteroscopy.
Okay, so this is endometrial cancer. Okay, this is endometrial. You've described it nicely. This is endometrial carcinoma. So we can see intermediate signal mass occupying the endometrial cavity. So if you look in the non-contrast T2 images, it will look slightly brighter than the outer myometrium. Okay, and following contrast, what happens? The myometrium, it enhances quite avidly, whereas the tumor does not enhance to that extent. So post-contrast images would give best contrast between myometrium and the tumor, and so would help to see if there is myometrial invasion. We'll come back to this slide again. So first, let's have a look at FIGO staging of CA endometrium. Now, staging of CA endometrium, CA cervix, and CA ovary have been asked in the exam. So it's important to be aware of the staging. In stage 1, it's confined to the uterus. Stage 1 again has stage 1A and 1B. Stage 1A, the tumor invades less than 50% of the myometrium, whereas in stage 1B, more than 50% of myometrium is involved. Now, why is this important? This differentiation is important. It's because myometrial invasion is a very good predictor of patient prognosis. So it is a very reliable index of lymphatic spread. And so regarding patient prognosis, the stage differentiation between stage 1A and 1B has got importance. In stage 2, it invades cervix. Stage 3, it extends to the adnexs or the ovaries. In stage 3B, extends to vagina and parametrium. And in stage 3C, the pelvic lymph nodes would be involved. And stage 4, there will be involvement of bladder and rectum and distal metastasis. Now, the sequences that we need to image endometrial carcinoma are, again, 3 planes of T2, T2 axial, coronal, and sagittal. There will be a T1 axial, T1 fat sat. We'll have additional sequences, diffusion weighted and ADC map. And then we'll have post-contrast sequences. In this case, we have acquired the post-contrast scans as a dynamic contrast enhanced imaging. That is sequential or serial acquisition of images following the contrast. Now, it is said that at 2 minutes and 30 seconds following contrast, you get maximum contrast resolution between the tumor and myometrium. And so that gives the best image to see the extent of myometrial invasion. This can be acquired as a single acquisition or using dynamic contrast imaging. Now, while you plan the axials of uterus or cervix in case of CS cervix, it's very important to get the true axial of uterus or true axial of cervix. So how is this planned? In the case of uterus, you have to plan the axial sizes perpendicular to the long axis of the endometrial cavity. And that results in the true axial of uterus. And that helps you to see the actual extent into myometrium and parametrial involvement. Same goes true for cervix. The axials are planned perpendicular to the long axis of endocervix. And that gives the true axial of cervix. Okay. Now we've come back to our same case. Now, can you stage this disease? This is endometrial CA. We've gone through the staging. Now the disease is confined to the uterus. So can you stage this disease now? Candidate 3? Yes. Okay, let me help you here.
Sorry, I was going to say, I think that there is some myometrial invasion, but it's...
Good.
I'm trying to decide whether it's more or less than 50%. I think I'm going to go with more.
Okay, sometimes it becomes a gray area, but if you actually look at the images, you can actually see the compact junctional zone there. Here there is extension into the inner myometrium. If you look at the outer myometrium, that actually shows a good thickness of the outer myometrium, shows enhancement similar to the rest of the myometrium. You are not seeing actually tumor extension into a good depth of outer myometrium. So there's less than 50% of involvement of myometrium.
Oh, okay.
So this is a stage 1A.
Okay.
And in the available axial images, you can see a few lymph nodes there. These are the lymph node criteria is, one is dimensions. So these were subcentimetric in short axis. The second is morphological appearance. So even if they are subcentimetric, if morphologically they looked round with areas of necrosis, then you would consider them as positive lymph node involvement. In this case, they do not fulfill the criteria, and so they were not highly suspicious. So if the lymph nodes were found to be positive, then the staging goes up to stage 3. Okay?
Yeah.
So we have also given ADC map. The tumor shows restricted diffusion. It's low on ADC map. Yeah. Candidate 3 again.
Yes. Okay, so on these selected transvaginal ultrasound images for a 60-year-old patient on tamoxifen, I think there is a large rounded heterogeneous lesion, which I believe is within the endometrial cavity. I can't see the superiormost portions of it on the first image, but on the second image, it looks like it's well rounded within the endometrial cavity.
Okay, good. So what is the cutoff for endometrial thickness if the patient is on tamoxifen?
Less than 5.
Less than 5 millimeters. Same goes for in the presence of postmenopausal bleeding. Again, less than 5 millimeter is accepted as normal. So here, the endometrium is quite markedly thickened. Quite markedly thickened. It's close to 4.5 centimeter. So we are worried about a endometrial CA.
Yeah.
So we have the MR images. Now, you don't have to describe it. Stage it. Give me the stage.
Okay. So I think that it is confined to the uterus, but on the post-contrast fat-saturated image, there is more than 50% involvement of the myometrium.
Excellent. So That would make
That would be
it
a 1B.
well done. So that's a 1B. So you can see the thickness of normal thickness of myometrium. So this tumor has involved more than 50% of myometrium, and the serosa, the outermost layer, is still intact. And there is no extension into the parametrium, no lymph nodes are seen. So this is a stage 1B. Very good. Now, given the diagnosis, this is a severe endometrium. Post-treatment, patient had vaginal stenosis and had residual tumor and hematocolpometra. So I would like you to describe the findings again.
Okay, so the uterine cavity is distended with high T2 signal seen within. Within this area of high signal, there is also an intermediate signal, almost lobulated lesion that someone has very kindly annotated.
Yep.
In the context of hematocolpometra, could this be a clot?
No, we have already given the diagnosis. So there is hematocolpometra and residual tumor. So I would like you to describe the findings, the uterine and cervical findings. So we know the diagnosis. So this is a single sagittal T2 image.
Mm-hmm. So the cavity is dilated, the wall appears thinned. There is low signal around the cervix, which
Yes.
also has low signal within it, and there is a fluid level.
Very good. Good.
Which would be a dependent fluid level.
Good.
The residual tumor itself is of intermediate signal near the fundus.
Yeah, good.
Yeah.
So what we are seeing here is a distended uterine cavity, which has got T2 high signal fluid, and what we know as the residual tumor in one corner. And what we can see here is dependent low signal fluid within the uterus and cervix. And ideally, if you're given a single T2 image like this, you should ask for T1 and T1 fat sat just to characterize the fluid, whether to know whether it is clear fluid or blood. So if a uterine cavity or cervix gets distended with fluid, it is only because its drainage is blocked. So that's why we suspected, we've diagnosed a vaginal stenosis here. So this low T2 signal is supportive of, is the only finding supportive of blood on this T2 image. If we had T1 and fat saturated images, then it would have been, it would have looked bright on T1 and fat saturated images. So this lady has history of Mirena coil insertion and presented with intermittent bleeding. So we can see on CT scan, we can see that the coil is within the uterus, centrally positioned. Describe the ultrasound finding, please.
Okay, so on the transabdominal ultrasound, there's a large area within the uterine cavity which is hyperechoic. I think it's part of the Mirena coil as well as a focal linear high echogenic.
So what do you think this hyperechoic area is within the uterus? So it's centrally within the uterus. Yes, go on.
I was going to say, could it be hyperplasia of the endometrium?
We can only say markedly thickened endometrium.
Okay.
Okay, so in a 50-year-old with intermittent bleeding, she is perimenopausal, sort of postmenopausal age acquiring. And so this becomes suspicious again for CA endometrium. And the coil is embedded within the thickened endometrium. This anyway needs further imaging with a MRI.
Right.
Would you like to describe the MRI findings? I have given sagittal, these are the pre-contrast images. I've given only T2 images now. So next slide will be the post-contrast images. So describe the findings on these selected T2 images.
Okay, so on these images, the uterine cavity appears to be distended and filled by an intermediate signal, mildly heterogeneous mass,
Good.
making the, I know it's a T, is it a T2? Yes, it's a T2.
Yeah, they're all T2 images.
Yeah.
Yeah.
So
before you continue, let me say these tiny cystic structures in the cervix are Nabotian cysts. Ignore them.
Okay.
Now continue with the rest of the description.
Okay, so I can't distinctly make out the endometrium from the myometrium or the junctional zone. And on the axial images, there's a lot of stranding around the uterus.
What does it mean? What does the stranding mean?
I think if I'm suspicious that there's a big endometrial mass, then these would be suspicious of serosal invasion.
Good, parametrial invasion. So when there is adjacent fat stranding, it's crossed the serosa and it's going into the parametrium. Good. And what am I pointing at?
A lymph node?
There's an enlarged lymph node there. And what is happening to the left adnexa?
I think in the left adnexa is that involving the left ovary within the mass?
It looks like it is extending to infiltrate into the left adnexa. And what about this slide? What is shown in this slide? What am I pointing at?
So I think that's involvement of the adjacent bowel loop, probably the rectosigmoid.
Good. And so now we have the post-contrast image. So that very clearly shows extension to involve the serosa of bowel and involvement of the ovary.
Yeah.
Can you see that?
Yeah.
For some reason, my slide is masked. Okay, yeah. And so, what stage will be? What is the stage?
Based on these, it would be at least a 4A.
Yeah, good. So there is bowel involvement. So that is stage 4A. So the earlier slide had shown parametrial fat infiltration near bladder, but in the post-contrast image, you can see the bladder wall is clear of tumor. There's no infiltration. Again, if this bowel involvement was not there, and if it stopped with ovarian involvement and lymph nodes, then it would have been a stage 3. Okay.
Mm-hmm.
Now, this is a CA endometrium radiology report checklist. So what we have to mention is the tumor size, depth of myometrial invasion, very important, cervical, vaginal, adnexal, serosal invasion, bladder, rectum or pelvic side wall involvement, lymph node involvement, presence of hydronephrosis, distant metastasis, and finally the ficostaging. Ficostaging we don't necessarily have to put in our report, but then these are the important points to be kept in mind. Yeah, candidate 3 again.
Okay, so on the selected T2 sagittal and I think axial images, there is an abnormality centered around the cervix where there is an intermediate signal mass.
Mm-hmm.
This is, I think, possibly invading superiorly into the uterine cavity.
Mm-hmm.
And on the axial image, there's an indistinct border posteriorly with maybe some stranding of that fat and extension to the rectal fascia. Yeah.
Okay.
So I would.
So what are we looking at? What is the diagnosis?
A cervical cancer.
Yep, this is a case of CS cervix. And let me take over now. CS cervix. So this is now confined to the cervix. The tumor is not involving anything anywhere else. It is confined to the cervix. Okay, so usually cervical tumors will be of intermediate signal on T2 and can be very clearly seen from separate from its bulky middle layer of fibrostroma. Now, if you're actually seeing a layer of T2 low signal fibrostroma all around it, then you can actually say there is no parametrial invasion. Okay, so this tumor is confined to the cervix, and so this will be a stage
1.
Stage 1. Okay, yeah. So this is cervical cancer staging. In stage 1, it is confined to cervix. In stage 2, it goes beyond cervix to involve the upper 2/3 of vagina, where it is 2A, and into the parametrium, where it is 2B, but does not extend to the pelvic side wall. In stage 3, it extends into the lower third of vagina as well and can involve pelvic side wall. And in stage 4, involvement of adjacent organs or distant metastasis. Okay, so coming back to our case, this is confined to cervix, so this is a stage 1 tumor.
Yeah.
Here is another tumor. There's a large bulky tumor centered on the cervix. It extends to the upper vagina. So when it extends to upper vagina, it becomes a stage 2A. And if you look at this, okay, let's look at the T1 here. You can see the tumor is extending and infiltrating the parametrium. If it involves, it is going up to the pelvic side wall. So when pelvic side wall is infiltrated, so that makes it a stage 3B. Good. So we are already looking at a stage 3B tumor. Additionally, we can see enlarged lymph nodes along the iliac group. There is an enlarged necrotic lymph node here. And in the post-contrast scan, you can see the tumor along with the nodes and its extensions, parametrial extensions are all enhancing. And you can clearly see that the rectum and bladder are not involved. So it is not a stage 4 disease, but it is a stage 3B disease. Now, by pelvic side wall involvement, what we mean is, if the tumor infiltrates to less than 3 millimeter of the pelvic side wall, which involves the obturator internus muscle or the internal iliac vessels or the levator ani muscle or the piriformis, any of these structures which form the pelvic side wall, if the tumor is within 3 millimeter of the pelvic side wall structures, then we call it pelvic side wall infiltration. Okay, so this is a stage 3B tumor. What is the extension and what is the stage?
So
the here is the axial one. Describe the extension.
I think there's extension inferior and anteriorly into the posterior wall of the urinary bladder. So I think that would make it a stage 4.
Good. So this is a stage 4 disease. So we can see, although this is a parametrial involvement is there, if the bladder involvement was not present, this would have been a stage 2B disease. Okay. So clear?
Yeah.
Okay. So this is a case of treated CA cervix. We can see T2 low signal filling up the cervix, which is of high signal on T1. So ideally, when you see a high signal on T1, you should have a fat saturated image. I don't have a fat saturated image displayed here, but it did not suppress on fat saturation. So this is a hematocolpos consequent to vaginal stenosis, consequent to treatment. Okay, so we have a CA cervix radiology report checklist here. The lesion is to be measured in 2 planes. You have to describe the tumor extent and all the extent to vagina, parametrium, adjacent structures, nodal status, presence of hydronephrosis, and distant metastasis. Okay? So just for completion's sake, this Chapman has given a lot of differential for abnormal filling defects on hysterosalpingography. So I've just collated a few images from online resources just so that you're familiar with them. these are filling defects. Submucous fibroid and endometrial polyps appear as filling defects on hysterosalpingogram. You cannot differentiate them on HSG. And bottom row is a completely distorted endometrial cavity, some irregular filling defects within the cavity. These occur when there are intrauterine synechia, and this is called Asherman syndrome. This can occur consequent to previous abortions or curettage, which can result to intrauterine adhesions. Additionally, you can see a hydrosalpinx also on the first image. Now, this is interesting. This is adenomyosis. You can see linear streaks of contrast extending into the inner myometrium from the endometrial cavity. So these are actually dilated endometrial glands. And so these are just a few images so that you know, you are now familiar with how they look on HSG. This is the last slide, I think, about the uterine abnormalities. What is the diagnosis? What is the study?
It's a HSG.
Okay, and what is your diagnosis? If you have seen this once before, then you would be able to answer. But if you have not, then it's a difficult answer, difficult to answer it.
I've not seen it before.
Okay.
But
So this is venous intravasation of contrast. So that appears when you're forcefully injecting contrast into the uterus. What happens is the contrast is intravasated into the venous and lymphatic channels of uterus. And you will not see an opacified uterine cavity. You will see a bizarre appearance of draining linear structures, and these are draining pelvic vessels. So once you see it, you will remember it. Sometimes the HSG may show a tiny uterine cavity, but this appearance of a draining vessel is characteristic. Okay, so this is venous intravasation of contrast. It is not a pathology by itself. It is because of the forceful injection.